And last but not least, more hypertension. Okay, so you know all about the JNC7. We've talked about that extensively. For this exam, you're responsible to know the JNC7 guidelines. By the time you guys take boards now, you definitely have to know the JNC8. Hopefully somebody's review course will address that. They even addressed it in the review course that I took, that this would be coming down the pike and that you'd be responsible to know that. So of course you need to know the pathophysiology of hypertension. There's many reasons why we have hypertension though, but the patho is all the same. And your typical diagnostic workup. Why do you think those CRP and homocysteine levels, hypertension sets in motion a huge inflammatory process that leads to cardiac disease? Okay, here is your JNC7 guidelines. You're not going to treat hypertension until stage 1. That's where you're starting treatments. Your 140 to 159s, 90 over 99s. Pre-hypertension, you're offering them diet and exercise options as well, and then also, of course, you're doing that with all the stages. But you can pre-hypertension, you're safe to do that, and you're operating within the guidelines. But at stage 1, that's where you're going to treat. Okay, here's all your benefits of lowering your blood pressure. I think everybody knows that. And your rational drug selection. Lifestyle modification first in pre-hypertension. That includes weight loss. The DASH diet is the hugest, there's the most benefit because you're reducing sodium and water. So with the DASH diet, you're not holding all that fluid, and that's kind of the goal to primary hypertension. You need to, when we start thiazide diuretics, you want to deplete the body of sodium and reduce fluid volume. So pretty much DASH diet acts as the same way that the drug does, except you don't have to swallow the drug. I think we've talked about too, whenever you do start somebody on a thiazide, you have to watch their potassium level, and if it's a loop, you definitely need to put them on potassium supplementation. So here's all your stepped up therapies. We all have these patients that come in, you've started a thiazide, it's not working, you've now started an ACE, it's not working, and on and on and on. So once again, here we go, your initial drug therapy. Your thiazides deplete your body of sodium and reduce fluid, so make sure that you know that. And I talked a little bit more about this loops. Remember, loops are thiazides. You need potassium supplementation, beta blockers to treat HTN because they reduce peripheral vascular resistance. I think we've seen this about on 3 slides. These also can make your symptoms of diabetes and asthma worse, both. And that's when you're going to pick the non-selective beta blocker. Okay, sites of action for your antihypertensive drugs. Here's where your ACEs work. Pretty much for this exam, you need to know everything there is to know about an ACE inhibitor. So they reduce sodium in water, they decrease vasoconstriction, and they increase vasodilation, and they are perfect for diabetics. Okay. So here's another thing too. This is an extra added sidebar, but it is in red, so you must need to know it for some reason. Many diabetics have a lot of protein in their urine. You'll see that if you have any kind of lab in your office. When you have an ACE and a non-dihydrocalcium channel blocker, there's a significant drop in protein in the urine. Okay, so that's a lot of times why you will see a diabetic on an ACE and a calcium channel blocker. But now what are we going to do all of a sudden if we have your diabetic who is on your ACE and your non-dihydro and they develop heart failure? We need to get rid of that calcium channel blocker because they are contraindicated in heart failure. Okay, so if diuretics are not the first drug given, they need to be added as a second drug. Example, if you started with an ACE and you still will not have optimal BP control, you're going to add a diuretic. So which patient population are you going to definitely start with a diuretic? That would be Asians, let's see, Native Americans, and African Americans, because of the risk of angioedema. That's why you're going to start with your diuretics and not your ACEs. So your most antihypertensive meds are in the generic form and are very cost effective, but there is a significant difference between an ACE and an ARB. ARBs are really expensive. indications for individual drugs. Post-MI, you must use a beta blocker. So that's beta blocker, ACE, and aldosterone antagonist. That's the order. Okay, and then there's other orders here, kidney disease and things like that. So make sure that you know, because you're going to have all these different patient populations coming in. Children and adolescents, this is a thing that we usually do head and chest measurements through the second year. Once your child is 3 years old in your primary care clinic, you're going to start taking blood pressures. So you need to know the normal pediatric norms if you're working in those environments. And patient variables, once again, we talked about African Americans have a higher incidence and respond best to diuretic therapy. Okay. And BP measurements. You have somebody that's rushed in from their ear clinic, they've had a big Starbucks, they have a cigarette in their car. You need to wait at least 30 minutes before you measure their blood pressure. And adherence issues. This is the big one. Your treatment plan can just be a debacle because a lot of the men do not want to take their blood pressure medicine because of sexual dysfunction. Beta blockers are notorious for that. Fatigue and depression. So lifestyle changes are also really hard to maintain and achieve. Drug cost is another thing that causes adherence issues, but usually most antihypertensives are pretty cost effective. And try not to make these, try to give one-time doses, not 2- and 3-time doses, and try to give combo drugs instead of multiple pills. For instance, if you need to add a thiazide and you're on lisinopril, just add lisinopril HCTZ. If you want to add separates for the first month and then combo them together after to make sure you're not having patients throw medications down the garbage, that's okay to do, but make it as easy as possible for your patients. And I'm hoping that's about it. I think that I think we covered most things. If I can think of anything, I'll post another quick review.